Today our topic is red blood cell disorders. Number 1, we are going to discuss about anemia. Reduction in circulating red blood cell mass presents with signs and symptoms of hypoxia. Number 1, weakness, fatigue and dyspnea. Number 2, pale conjunctiva and skin. Number 3, headache and lightheadedness. Number 4, angina, especially with pre-existing coronary artery disease. Hemoglobin, hematocrit, and RBC count are used as surrogate for RBC mass, which is difficult to measure. Anemia is defined as Hb less than 13.5 gram per deciliter in males and less than 12.5 gram per deciliter in females. Normal Hb is 13.5 to 17.5 gram per deciliter in males and 12.5 to 16 gram per deciliter in females. Based on mean corpuscle volume MCV, anemia can be classified as microcytic MCV less than 80 micrometer cube, normocytic MCV is equal to 80 to 100 micrometer cube, or macrocytic MCV greater than 100 micrometer cube. Firstly, we discussed about microcytic anemias. Basic principle of microcytic anemias are anemia with MCV less than 80 micrometer cube. Microcytic anemias are due to decreased production of hemoglobin. RBC progenitor cells in the bone marrow are large and normally divide multiple times to produce smaller mature cells. MCV is equal to 80 to 100 micrometer cube. Microcytosis is due to an extra division which occurs to maintain hemoglobin concentration. Hemoglobin is made of heme and globin. Heme is composed of iron and protoporphyrin A. Decreases in any of these components leads to microcytic anemia. Microcytic anemias include iron deficiency anemia, anemia of chronic disease, sideroblastic anemia, and thalassemia. Iron deficiency anemia. Due to decreased level of iron is less, heme then less, hemoglobin decreases, and microcytic anemia. Most common type of anemia, lack of iron, is the most common nutritional deficiency in the world, affecting roughly one-third of the world's population. Iron is consumed in heme, meat-derived and non-hemed vegetable-derived forms. Absorptions occur in the duodenum. Enterocytes have heme and non-heme transporters. The heme form is more readily absorbed. Enterocytes transport iron across the cell membrane into blood through ferroportin. Transferrin transport iron in the blood and delivers it to liver and bone marrow macrophages for storage. Stored intracellular iron is bound to ferritin, which prevents iron from forming free radicals through the Fenton reaction. Lab measurements of iron status. Serum iron, measure of iron in the blood. Total iron binding capacity TIBC, measures of transferrin molecules in the blood. Percentage saturation, percentage of transferrin molecules that are bound by iron. Normal is 33%. Serum ferritin reflects iron stores in macrophages and the liver. Iron deficiency is usually caused by dietary lack or blood loss. Infants breastfeeding human milk is low in iron. Children poor diets. Adults 20 to 50 years peptic ulcer disease in males and menorrhagia or pregnancy in females. Elderly colon polyps carcinoma in the western world, hookworm, in Cyclostoma duodenale and Necator americanus in the developing world. Other causes include malnutrition, malabsorption, and gastrectomy. Acid aids iron absorption by maintaining the Fe state, which is more readily absorbed than Fe3+. Stages of iron deficiency. Storage iron is depleted. More ferritin, less ferritin, more TIBC. Serum iron is depleted. Less serum iron, less percentage saturation. Normocytic anemia. Bone marrow makes fewer but normal sized RBCs. Microcytic hyperchromic anemia. Bone marrow makes smaller and fewer RBCs. Clinical features of iron deficiency include anemia, koilonychia, and pica. Lab findings include microcytic hypochromic RBCs with more R red cell distribution width, less ferritin, more TIBC, less serum iron, less percentage saturation, more free erythrocyte protoporphyrin. Treatment involves supplemental iron, ferrous sulfate. Plummer-Vinson syndrome is iron deficiency anemia with esophageal web and atrophic glossitis, presents with anemia, dysphagia, and beefy red tongue. Anemia of chronic disease. Anemia associated with chronic inflammation, for example, endocarditis or autoimmune conditions or cancers. Most common type of anemia in hospitalized patients. Chronic disease results in production of acute phase reactants from the liver, including hepcidin. Hepcidin sequesters iron in storage site by limiting iron transfer from macrophages to erythroid precursors, suppressing erythropoietin production. Aim to prevent bacteria from accessing iron, which is necessary for their survival. Less available iron, decrease hemoglobin, microcytic anemia. Lab findings include more ferritin, less TIBC, less serum iron, and less percentage saturation. More free erythrocyte protoporphyrin. Treatment involves addressing the underlying cause. Exogenous EPO is useful in the subset of patients, especially those with cancer. Sideroblastic anemia. Anemia due to defective protoporphyrin synthesis. Decrease protoporphyrin, decrease hemoglobin, microcytic anemia. Protoporphyrin is synthesized through a series of reactions. Aminolevulinic acid synthetase converts succinyl coenzyme A to aminolevulinic acid using vitamin B6 as a cofactor rate limiting step. Aminolevulinic acid dehydrogenase converts ALA to porphobilinogen. Additional reactions convert porphobilinogen to protoporphyrin. Ferrochelatase attaches protoporphyrin to iron to make heme. Final reactions occur in the mitochondria. Iron is transferred to erythroid precursors and enters the mitochondria to form heme. If protoporphyrin is deficient, iron remains trapped in mitochondria. Iron-laden mitochondria form a ring around the nucleus of erythroid precursors. These cells are called ringed sideroblasts, hence the term sideroblastic anemia. Sideroblastic anemia can be congenital or acquired. Congenital defect most commonly involves ALAS, rate-limiting enzyme. Acquired causes include alcoholism, mitochondrial poison. Lead poisoning inhibits ALAD and ferrochelatase. Vitamin B6 deficiency required cofactor for ALAS, most commonly seen as a side effect of isoniazid treatment for TB. Lab findings include more ferritin, less TIBC, more serum iron, and more percentage saturation iron overloaded status.